In this video, we break down immunosuppressant drug classes for pharmacy technicians, pharmacy students, nursing students, medical assistant and allied health students, patients and caregivers. Immunosuppressant drugs with clinical cases. Today, we're going to simplify immunosuppressant drugs. These medications reduce the immune system's activity. But why would we want to weaken the immune system? Two main reasons. First, to prevent organ transplant rejection. Second, to treat autoimmune diseases where the immune system attacks the body. Let's break this down step by step. Why suppress the immune system? The immune system is a double-edged sword. In the right context, suppressing it is not a compromise, it's a life-saving strategy. Prevent transplant rejection. After receiving a donor organ, the host immune system identifies foreign tissue as a threat and mounts an attack. Immunosuppressants prevent this rejection response, allowing the graft to survive long-term. Treat autoimmune disease. In conditions like rheumatoid arthritis, lupus, and inflammatory bowel disease, the immune system mistakenly targets the body's own tissues. Suppression reduces this pathological self-attack. Key principle. The goal is always targeted, titratable suppression, enough to prevent harm, without leaving the patient defenseless against infection or malignancy. Section 1. Corticosteroids. Let's start with corticosteroids. Examples include prednisone, methylprednisolone, and dexamethasone. These drugs work at the gene level. They reduce cytokines like interleukin-1, interleukin-2, and TNF, tumor necrosis factor. Think of steroids as the master-off switch for inflammation. Clinical case example. A 32-year-old woman with lupus presents with severe joint pain and kidney inflammation. She is started on high-dose intravenous methylprednisolone. Why? Because steroids act quickly to calm an aggressive immune flare. Key side effects. Hyperglycemia, weight gain, osteoporosis, increased infection risk. Important reminder. Steroids are powerful, but long-term use causes systemic side effects. Section 2. Calcineurin inhibitors. Next, calcineurin inhibitors. The two major drugs are cyclosporine and tacrolimus. These drugs block calcineurin. That prevents interleukin-2 production. No interleukin-2 means no T-cell activation. T-cells, T lymphocytes, are critical white blood cells of the adaptive immune system that originate in the bone marrow and mature in the thymus. They destroy infected or cancerous cells, regulate immune responses, and create memory cells for long-term immunity. These are cornerstone drugs in transplant medicine. Clinical case example. A 55-year-old man receives a kidney transplant. He is started on tacrolimus for long-term rejection prevention. 2 months later, his creatinine begins to rise. What is the concern? Nephrotoxicity, the most important side effect of calcineurin inhibitors. When you think CNIs, calcineurin inhibitors, think T-cells and kidneys. Section 3. Target of rapamycin, mTOR, protein inhibitors. Now let's move to mTOR inhibitors. Examples include sirolimus and everolimus. These drugs block the mTOR pathway. That stops T-cell proliferation, meaning immune cells cannot multiply. They are sometimes used as alternatives to calcineurin inhibitors. Clinical case example. A transplant patient develops worsening kidney function on tacrolimus. The physician switches to sirolimus. Why? Because mTOR inhibitors cause less kidney toxicity. However, the patient later develops high cholesterol and delayed wound healing. The unintended consequences. Despite preserving renal function, the switch introduces a new set of class-specific adverse effects. Hyperlipidemia. mTOR inhibition impairs lipid metabolism, leading to elevated LDL and triglycerides. Statin therapy is often required. Delayed wound healing. mTOR is central to cell proliferation and tissue repair. Inhibition can significantly impair post-surgical healing. a major concern in the perioperative period. Other class effects: pneumonitis, peripheral edema, and thrombocytopenia are additional mTOR inhibitor side effects to monitor. Section 4. Antimetabolites. Next are antimetabolites. Examples include azathioprine, mycophenolate mofetil, and methotrexate. These drugs block deoxyribonucleic acid (DNA) or nucleotide synthesis. If immune cells cannot make DNA, they cannot divide. These medications are used in transplant maintenance in autoimmune diseases like rheumatoid arthritis. Clinical case example. A patient with rheumatoid arthritis is treated with methotrexate. After several months, labs show low white blood cell count. What happened? Bone marrow suppression, a major side effect of antimetabolites. Always monitor blood counts. Biologics, targeted immune therapies. Unlike broad-spectrum immunosuppressants, biologics act on specific cellular targets within the immune cascade, offering greater precision with potentially fewer off-target effects. Rituximab. Target: CD20 antigen on B lymphocytes. Mechanism: depletes circulating B cells, reducing antibody-mediated rejection. B cells develop in bone marrow and are central to adaptive immunity and immunological memory. Basiliximab. Target: IL-2 receptor CD25 on T cells. Mechanism: blocks IL-2 receptor activation, preventing T cell proliferation, a key step in the rejection cascade. Belatacept. Target: CD80/CD86 costimulatory ligands. Mechanism: blocks T cell costimulation, interrupting full T cell activation without global immunosuppression. Key takeaway: biologics are more mechanistically precise than calcineurin inhibitors or corticosteroids, targeting discrete immune checkpoints rather than suppressing immunity broadly. These drugs are more precise than traditional immunosuppressants. Clinical case: rituximab in refractory rheumatoid arthritis. A patient with severe rheumatoid arthritis fails to respond to first-line methotrexate therapy. Her rheumatologist initiates treatment with rituximab, a biologic agent that depletes CD20 plus B cells, a cornerstone of RA management when conventional DMARDs fall short. Critical pretreatment safety step. Safety protocol: screen for hepatitis B before initiating biologics. Biologic agents, especially B-cell depleting therapies like rituximab, can reactivate latent hepatitis B virus, HBV, causing fulminant hepatitis and liver failure. Key principle: immunosuppression removes the immune check on latent HBV. Reactivation can be sudden, severe, and fatal if undetected. What to screen: HBsAg, anti-HBc, and anti-HBs before every biologic initiation. If positive, refer to hepatology. Consider prophylactic antiviral therapy. Entecavir. Closing summary. Let's review. Steroids, broad suppression. Calcineurin inhibitors block T cell activation. mTOR inhibitors block cell growth. Antimetabolites block DNA synthesis. Biologics, targeted immune blocking. One rule applies to all. If you suppress the immune system, infection risk increases. Understanding that principle helps you predict side effects and clinical decisions. And that's the foundation of immunosuppressant therapy. You can now access 2 complete CPHT exam prep ebooks. Drug classifications are fully organized and explained in the second book. Ebooks simplify your study process and help you focus on what truly matters. Visit the link below to purchase both ebooks today and start preparing the smart way. Cyclophosphamide is an alkylating chemotherapy agent with dose-dependent immunologic effects. It is not a true immunotherapy. Drug class: a alkylating agent. Nitrogen mustard. Cell cycle nonspecific. Causes DNA cross-linking apoptosis. High doses are used in chemotherapy or immunosuppression. At standard or high doses, cyclophosphamide acts as a cytotoxic chemotherapy drug. Mechanism: kills rapidly dividing cells. Effects: cancer cells, immune cells, T and B lymphocytes. Clinical uses: malignancies, lymphoma, breast cancer, ovarian cancer, severe autoimmune disease, SLE, especially lupus nephritis, vasculitis, systemic sclerosis, dermatomyositis, other, severe nephrotic syndrome, occasionally organ transplantation. Key concept: high doses of cyclophosphamide result in widespread immunosuppression. Low doses are used for immunomodulation. At low doses, cyclophosphamide has selective immune effects. Mechanism: a preferential depletion of regulatory T cells, TREGs. Enhances anti-tumor immune responses. Clinical implication: be used as an adjunct to immune checkpoint inhibitors. Helps make tumors more immunogenic. Important distinction: this is immunomodulation, not immunotherapy. That does not directly activate immune checkpoints or target immune receptors. Methotrexate. Methotrexate is always an antimetabolite, DHFR inhibitor. Dihydrofolate reductase, DHFR, inhibitors, a class of medications that block the DHFR enzyme, preventing the conversion of dihydrofolate to active tetrahydrofolate, which is essential for DNA synthesis and cell division. These antipholates are used to treat cancer, autoimmune diseases, and bacterial/protozoal infections. Whether it's called chemotherapy or immunosuppressant depends on the dose and indication, not the drug class. 1. Chemotherapy, high dose. A class: antimetabolite chemotherapy. A use: cancer treatment, e.g. leukemia, lymphoma, osteosarcoma. A effect: cytotoxic to rapidly dividing cells. Toxicities: myelosuppression, mucositis. A rescue: leucovorin folinic acid. 2. Immunosuppressant/immunomodulator, low dose. A class: antimetabolite immunosuppressant. A use: autoimmune diseases, rheumatoid arthritis, psoriasis, inflammatory bowel disease. A effect: lymphocyte. Immunosuppressant drugs mentioned in this video. True immunosuppressants are drugs primarily used for transplant rejection prevention or autoimmune disease control, even if they also have oncologic uses. Drug class: prednisone, corticosteroid, methylprednisolone, corticosteroid, dexamethasone, corticosteroid, cyclosporine, calcineurin inhibitor, tacrolimus, calcineurin inhibitor, sirolimus, mTOR inhibitor, everolimus, mTOR inhibitor, azathioprine, antimetabolite, mycophenolate mofdol, antimetabolite, methotrexate, low dose, antimetabolite, DHFR inhibitor, rituximab, biologic, anti-CD20, basiliximab, biologic, IL-2 receptor blocker, belatacept, biologic, co-stimulation blocker, cyclophosphamide, alkylating agent, dose-dependent.